hope that you can now see them on full screen. If there's any issue with the slides there, can you let me know? Because yesterday they weren't moving forward. So my topic today is antiretroviral therapy in this decade, the 2020s. Is there something to improve? There are my disclosures. And I'd like to introduce the topic. I'm going to really talk about the future of HIV treatment. Have we got a role for nucleosides? What about integrases? Are they the only way that we're going to go forward? Rapid start, what does it mean? How about 2-drug oral combinations? Who are they for? What about antiretroviral future as long-acting, as everybody's been saying? And finally, a little bit on quality of life. So the guidelines are here's 4 of them: EACTS, the DHHS, the ISUSA, and WHO. They're not consistent, as you can see. Yes, they all have integrases. Yes, they all have various nucleoside backbones. 3 of them had dual therapy. But if you're in the WHO guidance, you can see it's basically a single therapy as a public health approach. And if you're in the EACTS guidelines, you might say you've got a choice of very many things you can give to naive patients. So that's a really interesting phenomenon, because all of these guidelines have experts who sit and decide what they feel should be preferred or recommended. Now, will integrases continue to dominate the future? Well, the answer seems to be yes so far, because when you look at all of the studies of integrases versus other classes, you can see it usually favors the integrase. And if it's integrase versus integrase, it's usually non-inferior. And the other advantages, of course, of the 2nd generation integrases are low adverse events. And we really don't see much in the way of resistance in naive patients, especially when starting 3-drug regimens with integrases. But what about long-term data? Now, here's the 1489, 1490 long-term data on bictegravir with FTAF. And we can see that if you look at the missing equals excluded, in other words, basically on treatment, it works extremely well. But you can see that year by year, over time, we do have attrition, missing equals failure, people who probably don't have virological failure, but what they do is they're lost to follow-up, or they have adverse events, or they switch. And so we really need to bridge this gap, and how we do that in the future is probably in terms of managing patients better than we do today. Now, what about the role for non-nucleosides? And here's doravirine versus efavirenz, non-inferior, and against darunavir, a boosted PI again. And the issue really for most of us with doravirine is there's no comparison with integrases. So do we have enough? No, we need to see doravirine versus an integrase. And also there is a small risk of developing doravirine mutations if you fail triple therapy with doravirine, and that's another reason a lot of people prefer integrases. As you can see, EACTS have got doravirine as a one of the preferred drugs, and it's really related to the fact that doravirine is effective, but it's also got a very good safety profile, and its drug interaction profile is also excellent. What about nucleosides? So nucleosides, do we still need them? Well, in naive patients, you can see we use 2 or 1 nucleoside. In switch patients, we use 2 or 1 or no nucleosides. But when we switch patients who are detectable, we usually give them triple therapy and 2 nukes. So let's look at some of that data going forward about the role of nucleosides. Now, one of the principles for giving just 2 nucleosides was to remove drugs that might cause toxicity. For example, TDF with bone and renal, and abacavir with cardiac. Yes, if you remove that, you will reduce toxicity. What about drug interactions? Well, we haven't really seen very much of that happen, moving to 2 drugs. Fewer drugs, obviously. And has it really reduced the cost? Well, that's dependent on each country. Now, here's the famous Gemini study where they looked at naive patients and gave them dual therapy of dolutegravir 3-TC versus dolutegravir plus TDF FTC. So here we go, a naive study. The important thing is no hepatitis B infection and no major antiretroviral resistant mutations. And when you look at the data, it was all very good. But it was interesting that when we look at the patients who had a low CD4 count, there is a numerical difference. Now, this was mainly explained by people stopping therapy. But one of the other big issues is there was very few people, because they were excluded, with high viral loads. So we're being asked to start patients on a dual regimen, but excluding high viral loads. And this is reflected in the guidelines here. With the EACs, you should only use it if you're surface antigen negative and you've got a viral load less than 500,000. And the same sort of issues are reflected in both the DHSS and IAS USA guidance. So if we're going to ask ourselves, can we use dual therapy in patients with very high viral loads? We don't know. We need the data. And if you look at this STAT study where they started patients immediately without the results on dolutegravir 3-TC as first line, out of just over 100 patients, about 10 of them, 10%, had to change therapy. The majority you can see here because at baseline they had hepatitis B, and you know that this varies country by country, and many people have looked at this and said, well, we could have got our hepatitis B back very quickly, and there are point of care tests for this. You can see one person had a transmitted 184V, and a patient got pregnant. So if you do use this straight off without any tests, then expect to have to switch up to 10% of the patients. So we do need more data on dual therapy, at least an integrase plus 3-TC in naives. We also need to know whether this is effective in TB. And what about pregnancy? Are we going to give dual therapy to pregnant women who are naive, and we start them on that, or we switch them to two drugs and hope that will maintain their viral suppression? We don't know. And a lot of physicians say, is it better to start with triple therapy with 2 nucleosides, and when you're stable and undetectable, move to a single nucleoside? We don't know the answer to that question either. Now, what about switching when you're undetectable? Shall we give 3 drugs or can we give 2 drugs? Does it really matter? And you know, there are 2 studies earlier with boosted PIs and integrases, Dawning and Ernest, and they suggested that you might use just 1 nucleoside with a high barrier to resistant drug. So let's have a look. So the EACS guidelines say, yes, you can, as long as you've not got hepatitis B and no historical resistance. The DHSS say the same. You can switch, suppress patients as long as they don't have resistance. In other words, they're susceptible to both new drugs. And again, IAS USA provided both agents are fully active. So you can go to 2 drugs, but you have to know about their virological history and also any resistance if they've had virological failure. Here's the SALSA study. The other one was Tango, but this is a study where any 3-drug regimen was switched to 2 drugs, and you can see very good rates of suppression out to a year here. And you can see that the point estimate there favored dolutegravir 3-TC just about, but it was non-inferior when you looked at the margin here. So you can switch from any 3-drug regimen to 2 drugs, dolutegravir 3-TC. But here's some real world data that Paul Sachs presented just over a year ago. They looked at patients who were switching either 2 drugs or 3 drugs. And here's in the left-hand side, people who switched to 2-drug regimens, and they mainly switched to dolutegravir 3-TC or dolutegravir rilpivirine. And the interesting thing is that those who switched to 2 drugs appeared to have a higher virological failure rate compared with those who went on to 3 drugs. Now, this is pretty uncontrolled. We don't know all the details. I haven't seen this published yet, So it may be related to the populations these two drug regimens were given to, but it's just a marker to say that in the real world, we need the data as well to ensure that what we're doing is serving our patients. Now, there have been physicians who have switched to a two-drug therapy even when you've got 3TC or FTC resistance. And here's a SOLAR D switching to dolutegravir 3TC from a 3 or 4 drug regimen in patients with or without a 184V, as you know, the signature mutation for XTC. And you can see here the numbers of failures, 1 out of 50, 3 out of 50 on the ITT population. So those with a historical 184V, numerically, there were more patients who failed compared who had no resistance. The numbers are small, the differences are small, but numerically it's bigger. There's another study of more patients now. This is now 60 patients who have a history of 184V on prior genotype versus those that don't. And over the years, you can see here that probability of virological failure if you had a 184V in the past was nearly 12% compared with 6.3% if you've never had it. But it was really interesting data. And if you'd been suppressed before the switch for more than 3.5 years, you had a lower rate. Here we are, 184V and more than 3.5 years of suppression, a lower rate, 7.8, compared with if you didn't have that, and quite a big rate of failure at 22. If you look at the people with no 184 and less than 3.5 years of suppression, it was 9% versus 4. So all in all, this tells me that it's not a good strategy. They believe, the authors, that when you try and control for demographic and other characteristics, it's not associated with viral rebound. But this data to me speaks of why would you want to do this when we've got other therapies? It may be that if the patient's been undetectable for many years, that the 3TC mutation's lost. And here's some data looking at proviral DNA, looking at the loss of the 3TC mutation over time. You can see here, it's depend on whether you look at 2% or 5% pickup rates of the 3TC and the proviral DNA. You can see it's drops year by year. Whether you completely lose it, whether or not that's important, I don't know. But we did have some data earlier from a study called Spiral, where if you were more than 6 years suppressed, you did better if you switched to therapies which only had 1 or 2 active compounds. But when we look at this other data, I mean, this is switching to triple therapy in people with a pre-existing 184V. And you can see here with the 184V in the blue, it's just as good as with or without the 184V using triple therapy. And here's all of the different success rates. And basically, for me, I think that if I had somebody that I suspected or knew had a previous 184V, I wouldn't switch to dual therapy with an integrase and 3TC. I'd give them triple therapy. And you've got to ask yourself, are you increasing toxicity? Probably not. Are you increasing some security in terms of virological success? Probably yes. Rapid start. Well, what is rapid start? And recently the ISUSA say it's within 2 weeks. A lot of us think that rapid start is same day. Should we do it in the 2020s? Are we really moving towards this? Well, WHO, when they looked at a meta-analysis from low and middle income countries, they said, yes, it's a good thing to do because you decrease the mortality and you decrease the likelihood of loss to follow-up. And here's some other meta-analysis of studies. Yes, you do decrease mortality with rapid start, and you do improve viral suppression at 12 months. The rapid start definition, though, in most of these studies varied from 1 day to several weeks. And here's some data from South Africa, which wasn't so good. So in this first column is the same day. And in the same day, you can see people who are still on therapy, people who are lost to follow-up, people who had died, and people who transferred somewhere else or moved out. And you can see actually starting on the same day, it wasn't quite as good if you look at the number of people still actively in a study as those who waited 1 or 2 weeks or more. It may be related to the fact that this was in South Africa and people presenting to a certain clinic will move away to another clinic, and that's why the loss to follow-up is more. But I think we shouldn't accept that immediate same day is going to be better than 1 to 7 or more days. I'm a big fan of same day therapy, but we really need to study this in a systematic way before it's ready for prime time, I believe. And what about 2 drugs? Well, here's the 48-week data on 2 drugs, dolutegravir 3TC, and I really want you to look at the ITT analysis at 82%, missing equals failure. And I've already shown you 10 of the patients had to switch therapies. They couldn't be on rapid start. So I'm not sure whether this strategy of 2 drugs rapid start is going to be taken up in the next 5 or 10 years by people, and I think we probably will start triple therapy and then move to double therapy if we feel that's okay. The only caveat to this is if we have straight to say injectables where there are only 2 drugs, but we really need to see whether that works. Now, switching. I want to talk in switching the role of resistance testing, the role of integrases, and the role of nucleosides. So there are 2 difficult scenarios switching using 3 drugs. Now, you can switch when you're undetectable, but imagine you switch and you don't know what patients have failed. You know the drugs they've been on, but you don't know if they've failed, when they have failed, whether they've developed any resistant mutations. So, but you've given them a boosted PI, and of course, boosted PIs plus nucleosides often work. And you are now thinking, shall we move them off the boosted PI? Obviously, if you're detectable and you've got drug resistance, you can tailor the regimen. But this first scenario where perhaps you failed on efavirenz, you've moved on to a boosted PI, become undetectable, and you're wondering, can you move to an integrase? Can you use genotype? Can you look at their DNA, the proviral DNA? Unfortunately, it's got poor negative predictive value. If we just look at this second column here, you can see in 1 year, you found the mutations, in the next time you didn't, and then not in another. And so it's really quite difficult to use proviral DNA to give you the full picture of what they may have failed on in the past. So here we go, switching from a second-line boosted PI when you're undetectable, but in the past you've failed, probably on efavirenz, and you've got no resistant data, not even proviral DNA. This is a study I've been part of that was run in Kenya, and they switched people who had failed on mainly efavirenz-based regimens, gone on to a boosted PI, and they were now undetectable. And they switched half of the patients here to dolutegravir and 2 nucleosides. And actually it worked. So this is really important because we've got a lot of patients on boosted PIs. We want to move them off the boosted PI, maybe because of lipid problems, maybe because of drug interactions. And we're really concerned that if we move them off the boosted PI, they may develop virological failure. Well, I think you can rest assured you can move them onto the 2 nucleosides plus an integrase, and they should maintain a virological control. Here's the point estimate, almost on the line, and it's non-inferior. Now, switching when detectable is rather different. And again, what happens if you fail on a non-nucleoside plus either 3TC or FTC and TDF? Can you recycle the nucleosides? And this was a really fascinating study. So they basically got people with virological failure, mainly on NNRTIs, and failed, and they switched them on to either dolutegravir and darunavir, and they gave them a backbone of TDF3TC or AZT3TC. Now look at the left-hand side at the baseline resistance. Half of them had a K65R. nearly all of them had a 184V, and they had resistance to TDF, and most of them resistance to 3TC. You would not expect, if you switch somebody like this onto dolutegravir 3TC TDF, that they would do very well, but they did. And they actually did extremely well, whether you switch them onto dolutegravir or darunavir, or whether the backbone was TDF or zidovudine. And so there were some emergent integrase resistance, but all of those were seen in the dolutegravir AZT arm and not in the TDF 3TC dolutegravir arm. What does that mean? Well, that means that you can, if you're failing a non-nuke, switch to dolutegravir TDF 3TC or a boosted PI TDF 3TC. We've also shown that you could probably move from a boosted PI to a dolutegravir TDF 3TC. And so we've really got now a really good, if you start on NNRTI first line, you can move to dolutegravir second line. And if you failed that, probably to a boosted PI on third line. So it's really quite an interesting phenomenon we've moved into in terms of switching. But we've got 10 single tablet regimens. And even though we've got all of these, we still want something different. And that different thing is long-acting therapies. And you can see that, is this what we want? These are CAB, rilpivirine long-acting, and this is really now starting to be used quite in a widespread way in many parts of the world. And is this what the patients want? Well, in a big prospective surveys in 9 countries in North America, Europe, and Australia, yes, longer lasting therapy, please, so I can take my treatment less often. So this came in second after side effects. So you can see that patients do want long-acting treatments. And there are lots of them. They're long-acting oral on the way, injectables of all sorts of forms, topical mixed with contraceptives and implants and patches, lots of different things that we're going to see in the next few years. But there are opportunities, of course, about we don't need to take pills, less frequent dosing, maybe improved adherence. But there are also challenges at the moment with injection volumes, having to come to the clinic, what happens if you miss a dose, various opportunities and challenges for the current long-actings. Now, here's long-acting CAB and rilpivirine, lots of different studies. Adverse events are very small. That it's been non-inferior to oral therapy out to 152 weeks. Resistance I'm going to talk about, but it's uncommon. The problem is, of course, at the moment, unless you can use it with an oral lead-in, but also you can go straight to injection. And the patients have preferred it, 9 out of 10. Remember, though, there were patients in studies, so they wouldn't have gone in the study if they didn't want to have the opportunity of an injectable. Now, this is fascinating because who should you not give long-acting cabotegravir and rilpivirine to? Well, those patients who have got rilpivirine mutations. Well, that's pretty obvious to all of us. But initially, they said, if you just had that, you might still succeed. But actually, I think they've changed this now. And so any rilpivirine RAMS is a no to giving this therapy. If you've got subtype A6 or A1, you shouldn't give it. This can occur in Eastern Europe and parts of Africa. However, we are only now starting to look at our subtype A's and divide them into subclades of whether they've got A6 or A1. And this may not be available to you guys in Latin America. Baseline BMI, a high BMI over 30, we wouldn't give it. And you can see that any of these, if you get 1 factor or 2 factors or more, you get you can get 2%, 20%, up to 20% failure rate. Now, interestingly, some patients fail with none of these factors, even though they're having regular injections. And you can see in this Carlos cohort, I've just put here from Germany, very good results in terms of undetectability. But there was 1 patient here with emergent integrase resistance. They had on-time injections. Their BMI was good. They had HIV subtype B. 1 patient was given off-label. And when they failed, they had NNRTI RAMS. and they did have previous non-nuke failure, but we don't know about their resistance at that time. So, and they had a BMI of 20 and subtype C. So you can fail without those risk factors, and overall, the risk of virological failure and resistance for injectables is 1 in 70 at year 1 and about 1 in 60 at year 2. We really need more real-world data because it's mainly being investigated in the context of viral suppression in selected populations. So we need to have more data, and we are collecting that now as it rolls out. Just a little bit more about implementation of this. The adherence needs to be within a 7-day dosing window, and you can see the 6% this side had it early, and this 2.8% overall had it late. So some people are coming in late for their injections, and we've got to have good systems to make sure that they have their injections within the window. The other problem, and it's really important, is that with long-acting injections at the moment, they have to come to a clinic and have an injection in the clinic. Now, this is one of the issues, and it will be the issue with PrEP as well, with long-acting injections, is that we're remedicalizing patients. We're making them much more patients than they used to be when they come in every 6 months, pick up their drugs, have a blood test, and go home. And so we have to find a way with long-acting to demedicalize, to simplify, and to make sure we can give these injections, all long-acting therapies, outside of the clinic. We really have to think about remote settings. And I know this is a picture of people in Africa, but you have plenty of remote settings in Latin America. Now, what about other pills that might long-acting pills? Well, that's islatravir, and we have to wait about news of an implant. This is a really interesting translocation inhibitor, and it was under evaluation for prevention and treatment. But as in the dose ranging study, it did extremely well at all of the doses compared with triple therapy. And this is where it was given as triple therapy and then given as islatravir and doravirine as a dual therapy. So it was working really well. But then last year, almost a year ago to the day, they had a hold on the studies because of the CD4 count issue. And here it is. So I just talk you through this quickly. If you look at the high dose of islatravir in the pink here, you can see that over time, the CD4 count starts to drop. And it seems to be dose ranging. Here's the 2.25, here's the 0.75, and really no effect here on the 0.25. And here is in the red here, the doravirine without islatravir. So the 0.25 didn't have an issue, it was these two. And that's total lymphocytes, and exactly the same with the CD4 count. And interestingly, what happened here, I'll just show you. In the green, these islatravir 0.25, no effect out to week 48. And then these people were switched to a 0.75 milligram dose. When they were switched, the CD4 went down. Now, when you look at the high dose here, 2.25 milligrams, here are patients who switched to the 0.75 and their lymphocytes started to increase. So the high dose, switching to a lower dose, you get improvements in the lymphocytes. The low dose, switching to a higher dose, you get deterioration. So it's a dose response CD4 cell problem with islatravir. And they've modeled it now. And here's 3 doses, 0.1, 0.25, and 0.75. Obviously, they can't use the 0.75, and they're going for this, the 0.25, because here is the cutoff for wild type, and here's the cutoff if you happen to have a 184V, and you can see you just about you start to get above the IQ for the 185V at 2 weeks. For the wild type, you're almost immediately above by day 2 or 3. So we have to wait and see what goes on, but they are now going ahead with the 0.25 milligram dose. And so here it is, the phase 3, the 0.25 milligram dose, and they're looking at switches, and hopefully they're going to go back to look at islatravir and lenacapavir. And here's lenacapavir. It's a capsid inhibitor with various parts of the pathway that it inhibits. It's got this big study called Capella, and basically there was a randomized and non-randomized cohort. The randomized had lenacapavir and continued their failing regime versus placebo and the failing regimen, and then the background was optimized. We had very good results with lenacapavir, and if you had more active agents, you did better. So lenacapavir given by oral loading dose and then subcutaneously every 6 months. And you can see here that here's the whole cohort. Not so good a response in less than 200 copies and high viral load. We see this in lots of different drugs, that high viral load and low CD4 responses aren't so good, but we need to have more data. This is quite a small study. You do get resistance to it, and so it's got a relatively low barrier to resistance with the 66 and 67 mutations, and you can get nodules, but it's nothing like we saw with T20. The nodules are grade 1. They resolve pretty quickly. They look like they're an allergic phenomenon rather than a drug phenomenon, and very few patients. There's one patient discontinued because of nodules, so they're quite uncommon. Now, these new drugs might help heavily treatment-experienced individuals, but actually, when you look at the population of heavily treatment experienced, even the multi-drug resistant and the people who've lost treatment options, most of them are actually virologically suppressed. We've done really well with integrases, with boosted PIs, with recycling nucleosides, and with other drugs. And we've got very few patients actually who are not suppressed, not virologically suppressed, who might need new drugs. But we might move some of these other patients off boosted PIs with a new drug so we don't get drug interactions or side effects of the boosted PI. And this is the action of fostemsavir, and some of these people also had ibalizumab, another drug, but we can't get that in Europe, and I'm sure it's not only available, I think, now in North America. But here's fostemsavir, again, in the randomized cohort, we're given it very good responses to these heavily treatment patients. As you know, fostemsavir has to be given twice a day. So I think that in the next 10 years, we'll probably see even fewer patients who are detectable and very few treatment options. And it may be we'll be using some of these newer drugs to switch away from boosted PIs. So what we should finally aim for, of course, is 90-90-90 or 95-95-95 by 2025. But also, we must make sure that whatever our antiviral therapy is, we give a good quality of life to our patients. So in summary, can we improve? Well, we have to define the future of HIV treatment, and that is through research, clinical trials, real-life data collection, cohorts. What are we going to do with nucleosides? Some long-acting therapies have a form of nucleosides in terms of islatravir, but really there's very little role for those in long-acting therapy. There is a long-acting Truvada implant being developed, but where are we with those? Where are we with dual therapy with nucleosides? Are we sure that integrases is the only way to go? Well, islatravir lenacapavir does not have an integrase, so maybe we'll see a diversion away from integrases in the future. Rapid start, well, we need better data. We really do need a big randomized clinical trial to see what the benefits are. As I say, 2 drug oral combinations, who are they for and in what situation? And we're now moving to this long-acting future. Is this going to be the major thing that we do, or will it just be part of our drug menu when we're talking to patients? And we do need data, more data, of course. We need long-acting with longer dosing intervals, and it would be lovely to have a zero-resistant regimen. Finally, whatever we do with all of these things, we need to start measuring the quality of life of our patients to ensure that they are happy with what they're prescribed and have a big say in what they are given and how it's researched. And with that, I'd like to thank you very much indeed.